Let's discuss which initial mode of ventilation should be selected. Although there are numerous options for selecting the initial mode, assist controlled volume ventilation is the most common ventilator mode used throughout the world as a primary initial mode of ventilator support. Now the question is, why would the AC mode be preferable over the other modes, like for example the SIMV, synchronized intermittent mandatory ventilation mode? Don't both of these modes offer good ventilator support? Well, to answer this question, let's see how the two modes work and then focus on why the AC mode is preferable over the SIMV mode. Suppose we set newborn patient on the AC mode and we set respiratory rate to a rate of 40 breaths per minute. That means that if you do 60 seconds divided by 40 breaths in a minute, the baby will receive a breath every 1.5 seconds. In this example, the baby is not attempting a breath, but every 1.5 seconds a fixed volume will be delivered regardless. Here we have set a mandatory volume of 8 milliliters, so every time we breathe, there will be a volume of 8 milliliters being delivered. But let's say before the 1 second mark, the patient attempts a breath. What happens? Well, in assist control mode, the patient merely attempts to trigger a breath and the ventilator will take over and deliver the full set tidal volume. Notice how the delivered volume is the same as the other breath where there was no patient trigger. This is what makes the AC mode preferable for the initial mode. Remember, the goal of initiating mechanical ventilation is to alleviate the work of breathing of the patient and to allow the ventilatory muscles to recover. This mode is ideal for muscle rest and recovery because the patient doesn't have to work so hard to get the full volume breath. They just merely have to initiate or trigger a breath and the ventilator does the rest. So now, let's compare this to the SIMV mode. In the SIMV mode, we can copy the same settings with a respiratory rate of 40 and a tidal volume of 8 milliliters. And if you look closely, you'll see that the breath will be delivered every 1.5 seconds, just like in the AC mode. So you should be asking yourself this question, then what is the difference? Let's imagine what a patient-triggered breath would look like at the 1 second mark in this SIMV mode. And remember, initially this patient most likely will not have adequate muscle strength since they probably have an acute ventilatory muscle dysfunction and fatigue. Notice how the SIMV mode, the full 80 milliliters isn't reached. The baby is responsible for the volume received during a spontaneous or a triggered breath. And initially, when the baby is weak and the lungs are impaired, the baby may not be strong enough to draw a full breath, so this type of shallow breathing may actually contribute to hypoventilation and continued respiratory muscle dysfunction. On the other side, when we compare both modes of ventilation, as we have already seen with the AC mode, the baby merely attempts and the ventilator does the rest. So yes, the ventilator will allow for spontaneous breathing during the SIMV mode, which in theory seems like a good choice because it gives the babies freedom to determine their own volume. But this may not be such a good idea when initially placing a newborn baby with respiratory distress on a mechanical ventilator. So, when you think about the initial goal of mechanical ventilation, which is to reduce the work of breathing and to allow for ventilatory muscle rest and recovery, then it should come as no surprise as to why the assist control volume ventilation mode is the most common ventilator mode as a primary initial mode used throughout the world. Are there inherent challenges with the AC mode? Absolutely, and I will discuss those later on. Now let's move to another question that we should be asking in this lesson. We use the controlled tidal volume as a means to inflate the lung from breath to breath. So here is a question. Why did we select volume ventilation, in this case the 8 milliliter of volume, instead of filling up the lungs to a set of controlled pressure? In other words, why did we use volume ventilation instead of pressure ventilation? And this is a great question, and I'm really glad you asked it. And we'll discuss and answer this very important question in the next video. So I hope you like this video. And finally, my friends, make sure to like and share this video. And thanks for watching, and I hope to see you again soon.